Hey guys, Nick here. Welcome back and welcome to Renal Pharmacology. In the course of understanding renal physiology, we've already laid the groundwork for the vast majority of these drugs. So let's get after this pharmacology so we can hammer home these concepts. As we go forward with diuretics in this section, you can use this page as a reference to remember where in the nephron each drug acts and how that can be used to predict its effects. Understanding where each diuretic acts in the nephron is important. The location will determine their overall effectiveness in eliminating water from the body. Let's start with acetazolamide. Do you remember from our earlier lectures how this drug works? It inhibits the carbonic anhydrase enzyme in the proximal convoluted tubule. Now, as a diuretic, do you think this drug has a major or minor effect? Its effect is relatively minor because whatever solutes acetazolamide prevents from being reabsorbed can actually be reabsorbed downstream in the later parts of the nephron. In contrast, the loop and thiazide diuretics have stronger diuresis effects because they work at sites of major iron reabsorption. And where are these sites? Loops work at the thick ascending limb, while thiazides work at the distal convoluted tubule. The nephron just doesn't have much of a mechanism for reabsorbing solutes distal to these sites. On a similar note, why do you think potassium-sparing diuretics and ADH antagonists have relatively minor effects in terms of diuresis? Well, like we said, most of the ions in water have already been reabsorbed by the time filtrate reaches the collecting tubule. Let's start off with a drug we haven't mentioned yet, mannitol. This is a sugar that is freely filtered by the glomerulus but then not reabsorbed. The excess solute in the lumen causes an osmotic diuresis. The clinical uses for mannitol are diuresing hydrophilic drugs during a drug overdose and reducing intracranial and intraocular pressure. Toxicity includes pulmonary edema and CHF if too much mannitol is given because it can pull water out of the cells and into the interstitial space. If patients are diuresed too much, they can become dehydrated. It's contraindicated in anuria because patients will not be able to excrete the mannitol. And this will cause what? Well, it will pull waters out of the cells into the interstitium. On the exam, look out for mannitol being given during a neurosurgical emergency to reduce the intracranial pressure. The next drug is acetazolamide, which is a carbonic anhydrase inhibitor that we've already talked about. By inhibiting carbonic anhydrase, bicarbonate is not reabsorbed because it's not converted into what? Correct, carbon dioxide. This causes bicarb loss and sodium loss in the urine. It's primarily used for glaucoma because it reduces aqueous humor pressure. With all this bicarb in the filtrate, this drug will alkalinize the urine and prevent the formation of certain kidney stones. Now, which type of kidney stones do you think we're talking about here? Well, uric acid and cysteine kidney stones, which precipitate at an acidic pH. It's also used to treat metabolic alkalosis because it removes bicarb from the body. In patients with acute altitude sickness, they will generally be breathing quickly, creating a state of respiratory alkalosis. Acetazolamide is a great treatment for this condition because it will enhance the elimination of bicarb. This will help to maintain a normal blood pH. Please remember this association with acute altitude sickness because it's often tested on step 1. The main toxicity of acetazolamide is metabolic acidosis due to the loss of bicarb in the urine. And it can also cause paresthesias, ammonia toxicity, and a sulfa allergy because of its sulfa origin. Flash quiz. In what two conditions is mannitol contraindicated? Anuric renal failure and congestive heart failure. Remember that if mannitol builds up, it can pull water out of cells, causing interstitial edema, which would be dangerous for an anuric patient or a patient with CHF. The next drug, furosemide, is in the class of loop diuretics and is very important in clinical medicine. As we've already talked about, it's a very powerful diuretic that works by blocking the sodium-potassium 2-chloride cotransporter, leading to sodium chloride, potassium, and water loss. This reduces the hypertonicity of the medulla, which will do what to the ability of the kidney to concentrate urine? Well, the kidney will no longer be able to count on the countercurrent system too concentrate urine. It also stimulates prostaglandin E release, and this causes a vasodilatory effect on the afferent arteriole, thus increasing GFR. Also, remember that loops lose calcium, and therefore can be dangerous in patients with what clinical condition? Osteoporosis. Furosemide is a very important diuretic that's used to eliminate fluids in acute edematous states such as CHF and cirrhosis, and it's also a common drug used to treat hypertension and hypercalcemia. However, it can have some serious adverse effects. The way to remember this is with the mnemonic ODANG: ototoxicity, hypokalemia, dehydration, allergy because it's a sulfa drug, nephritis, which is interstitial, and gout due to hyperuricemia. The next loop diuretic is ethacrynic acid. It works in a manner similar to furosemide and has the same toxicities too. A critical thing to remember about this drug is that it's not a sulfonamide, and this is commonly tested. If a patient presents with CHF and is given furosemide and develops an allergic reaction, next time they have a CHF flare, you wouldn't give them furosemide again. Ethacrynic acid would be your drug of choice. Hydrochlorothiazide is the prototype of thiazide diuretics. It works by inhibiting the sodium chloride cotransporter in the distal tubule, leading to sodium chloride, potassium, and water loss. The distal tubule is important for diluting the filtrate, so inhibiting this cotransporter reduces the ability of the nephron to do what to the urine? Well, the nephron can no longer dilute the urine. Therefore, more ions are excreted. Hydrochlorothiazide also increases calcium renal absorption. Its clinical uses include hypertension, CHF, idiopathic hypocalciuria, and osteoporosis due to the reduced calcium excretion. Patients with nephrogenic diabetes insipidus are given thiazides to slightly dehydrate them, thus decreasing plasma volume and GFR. This ultimately leads to an increased proximal reabsorption of sodium and water, thus helping the patients to maintain a low but somewhat normal plasma volume and not have to urinate all the time. The important toxicities that thiazides can cause can be remembered with the mnemonic hypergluc: hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Also, sulfa allergies because they're sulfa drugs. Flash quiz. Blank increases calcium excretion, whereas blank decreases calcium excretion. The answer is furosemide and hydrochlorothiazide. Remember that loops lose calcium because they make the lumen potential more negative, and thiazides save calcium because they make the lumen potential more positive. Potassium-sparing diuretics can be remembered with the mnemonic the K stays. They are spironolactone, eplerenone, triamterene, and amiloride. Spironolactone and eplerenone act as competitive aldosterone receptor antagonists in the cortical collecting tubule. Triamterene and amiloride act at the same part of the tubule but block the sodium channels, thus increasing sodium excretion. These diuretics are used for hyperaldosteronism as diuretics in potassium-depleted patients and CHF. Toxicity includes hyperkalemia and an anti-androgen effect of spironolactone, which may lead to what physical finding in males? Correct, gynecomastia. Flash quiz. A 56-year-old man comes to your office for blood pressure follow-up. He currently takes furosemide daily. His blood pressure is 145/98, and his serum potassium is 2.9. Which of the following drugs would make the best addition to his regimen? Hydrochlorothiazide, triamterene, mannitol, or acetazolamide? The answer is triamterene. All of these agents can be helpful in lowering the patient's blood pressure, but he is also hypokalemic, and triamterene is a potassium-sparing diuretic that will increase his serum potassium at the same time. Now let's look at what the overall effects of diuretics are on the electrolytes. All diuretics increase urine sodium chloride excretion, except acetazolamide, which increases the excretion of what? Sodium bicarbonate. Urine potassium is increased with loop diuretics and thiazide diuretics. Blood pH is decreased with carbonic anhydrase inhibitors. Why is this? Because they're increasing bicarbonate excretion. Blood pH is also decreased with potassium-sparing diuretics. Now why does this happen? Aldosterone inhibition prevents hydrogen ion secretion, and hyperkalemia leads to potassium entering the cells and hydrogen exiting the cells. Both mechanisms lead to a decreased blood pH. Loop diuretics and thiazides increase blood pH. This is due to volume contraction, which leads to increased angiotensin II levels. Do you remember how angiotensin II acts in the nephron? It will activate the sodium-hydrogen ion exchanger in the proximal tubule. Secondly, potassium loss from the plasma leads to potassium exiting the cells and hydrogen ions entering the cells. Finally, in a low potassium state, hydrogen ions are exchanged for sodium in the cortical collecting tubule, which increases hydrogen ion secretion. All three mechanisms lead to an alkalotic state. Urine calcium depends on its paracellular reabsorption. Urine calciums increase with loop diuretics because they increase reabsorption. In contrast, urine calcium is decreased in thiazide diuretics because they decrease this reabsorption. The next class of drugs we'll discuss is the ACE inhibitors. Now all of these drugs end in pril. They function by reducing the levels of angiotensin II, which has a number of distinct effects that lower blood pressure. By inhibiting ACE, they cause efferent arterial vasodilation, and they increase bradykinin levels, which is a potent vasodilator. Their primary use is for hypertension, but they are also used in heart failure because they prevent heart remodeling, and in diabetes because they slow down chronic kidney damage. They are also helpful in proteinuria due to the efferent arterial vasodilation. The side effects of ACE inhibitors are often the thing that prevents them from being used. They can be remembered with the mnemonic CATCH, C-A-T-C-H-H. The most common is cough, and it's caused by the increased bradykinin levels. Other side effects are angioedema, especially in patients with C1 esterase inhibitor deficiency. ACE inhibitors should not be used in pregnancy because they are teratogenic. They can also lead to increased creatinine levels, hyperkalemia, and hypotension. An 82-year-old man with a history of multiple myocardial infarctions presents to your office with peripheral edema. Lung exam reveals bilateral crackles, and neck exam shows distended veins. In the acute setting, which of the following drugs is most indicated? Lisinopril, furosemide, or spironolactone? The answer is furosemide. The patient in this case is in acute heart failure and needs a diuretic to remove fluid. Furosemide is a much stronger diuretic than spironolactone, so that's the best choice. As a side note, lisinopril is useful in chronic heart failure to prevent remodeling, but it isn't that helpful in the acute setting when the goal is removing fluid. The next class of drugs is the angiotensin II receptor blockers. These drugs will also all have the similar ending of sartan, so be sure to recognize that in your answer choices. These drugs selectively inhibit the angiotensin receptor, leading to very similar effects as those seen with ACE inhibitors. However, angiotensin receptor blockers do not increase bradykinin levels. Since bradykinin levels won't be elevated, what side effect will these patients not have? Correct, a cough. These drugs will therefore be a great alternative for those patients taking an ACE inhibitor but cannot tolerate the constant cough associated with the medication. Its clinical indication will again be very similar to those calling for ACE inhibitor use, such as hypertension, heart failure, proteinuria, or diabetic nephropathy. Now, as for toxicity, they will follow a similar pattern to their ACE inhibitor counterparts outside of the absence of cough we just discussed. Can you then guess some of the toxicities associated with these drugs? Hypertension, a decrease in renal function, and hypotension. This is the final drug we'll be discussing for renal pharm. Aliskiren is a unique drug that is a direct renin inhibitor. Do you remember the function of renin? Correct. It converts angiotensin to angiotensin I. Without this conversion, angiotensin II cannot be created. Its only clinical indication is hypertension. So right now, this is turning out to be a pretty simple drug. The toxicities are also pretty similar to what we've seen in both the ACE inhibitors and ARBs. Hyperkalemia, a decrease in renal function, and hypotension are those toxicities you want to watch out for. One unique contraindication to the use of Aliskiren is in diabetics taking ACE inhibitors or ARBs. You don't want to add a drug to a regimen that might potentially worsen the renal function in a patient that's already predisposed to kidney damage, i.e. a diabetic on an ACE or an ARB. Alright folks, that about does it for our adventures here in renal pharmacology. Let's finish it off with a board-style question. A 45-year-old man presents to his primary care physician with a blood pressure of 160/90 that has failed to drop substantially after the initiation of lifestyle changes. He has no medical history and takes no medications. The patient is subsequently given an antihypertensive medication. On a follow-up appointment, his laboratory results are sodium of 133, potassium 5.4, bicarb of 33, glucose of 166, and urine calcium of 50. Which of the following represents the site of action of the medication he was most likely given? The correct answer is B. This patient presents with metabolic alkalosis, hyperglycemia, and low urinary calcium excretion, which are common adverse effects of thiazide diuretics. Remember that thiazides inhibit the sodium chloride cotransporter on the luminal surface of the distal tubule by binding to the protein's chloride site. Great job! That finishes up the renal chapter. My advice is to focus on understanding the concepts before you focus on memorizing the details. You'll maximize your potential for success on the exam. Keep your heads up, stay positive, reward yourselves throughout this studying marathon, and you'll be just fine. Remember, repetition is the key to adult learning, so keep running through these concepts to make sure you have them down. Until next time.